listening test. This test has 3 parts. In each part, you'll hear a number of different extracts. At the start of each extract, you'll hear this sound. You'll have time to read the questions before you hear each extract, and you'll hear each extract once only. Complete your answers as you listen. At the end of the test, you'll have 2 minutes to check your answers. Part A. In this part of the test, you'll hear 2 different extracts. In each extract, a health professional is talking to a patient. For questions 1 to 24, complete the notes with information you hear. Now look at the notes for Extract 1.
Extract 1, questions 1 to 12.
You hear an addiction specialist talking to a new patient called Cheryl Tyson.
For questions 1 to 12, complete the notes with a word or short phrase. You now have 30 seconds to look at the notes.
Hello, come on in. You must be Mrs. Tyson. I received your file from your GP about your ongoing problem with pain.
Yes, that's right. I asked to see a specialist after my GP said there are ways to come off opioids and deal with the long-term pain I have.
Right, and I understand your ongoing medical condition started with a surgery. Can you tell me more about that?
Yes. I wore my back out working in a warehouse. After so many years of heavy lifting, I developed sciatica in both legs. Pain was unbearable. I couldn't sit, so I couldn't go to my work. I was also having trouble sleeping.
Right. Was it at this time you were prescribed opioids?
Not at that point. For a while, my GP told me to take over-the-counter pain relievers for the pain. Later, I was prescribed muscle relaxants, but that didn't work well, so I had microdiscectomy surgery. They said this type of surgery had a high rate of success and it had quick recovery time because it was relatively minimally invasive.
I see. So you were prescribed opioids after the surgery?
Exactly. I was put on loads of different painkillers by my doctor after the surgery. I can't remember all their names, but I know one was Coproximol. They told me it was a paracetamol and opiate mix. I kept taking it because even after my surgery I had chronic back pain.
How many times a day were you taking that?
I was taking 12 to 14 a day.
That is nearly twice as much as you should have been taking. Was the pain medication actually helping with the pain?
To start with, it did help. But then I started to get breakthrough pain and I had to increase the dose. At one point, I was on a slow-release tramadol. I was only supposed to take 1 a day, but after a while, I got up to 3 a day.
Your body was becoming intolerant to it at that point. During the time that you were taking 3 times the prescribed amount, what side effects were you experiencing?
I didn't know it at the time, but I had quite a few side effects. The most serious was severe constipation and nausea. There were days when I didn't want to leave the house because of it. The medication also affected my mood quite a lot. I felt low and I became withdrawn. No friends, no social events. I even contemplated suicide at one point.
How about memory loss or fuzziness?
I have had a couple of episodes of memory loss. I remember one time I was on my way to work from dropping my son off at uni and I couldn't remember which route to take. Then I started to feel paranoid, like everyone was noticing that I was lost. So I started to drive fast and get ahead of the traffic. Then I was afraid of getting stopped by the police, so I started to drive very slowly. That is when I knew I was a danger and needed to do something to get my life back. That was 2 months ago.
How long between when you started taking painkillers and that incident with your memory?
10 years.
Did any of the doctors that you see during that time suggest you cut down on your painkillers?
No, not until I changed GPs. My new GP told me that many of the symptoms I was reporting, like the nausea and memory loss, were side effects of the painkillers. No one had ever told me that before.
I'm not that surprised. There's little guidance and support at the moment for GPs to help people to taper off their opioids safely and be able to manage their pain using non-drug techniques. For many years, doctors were trained to give opioids to people in pain.
Yes, that's what my current GP told me.
We have developed a package of care that involves a multi-pronged approach. The first phase involves 3 days with a specially trained nurse. You will learn about what opioids are, how they work in terms of pain, and the nurse will start to give you drug-free pain management techniques. Then you will move on to your group. During group work, you will learn stress management techniques such as learning to use relaxation, as well as cognitive behavioral approaches, which involves changing your thinking patterns and putting in place goals for yourself. After the group element of the program, you will start to have a one-to-one session with a nurse who will generate a tapering plan to help you reduce your intake of opioids. This nurse will serve as a point of contact once you leave the intensive phase of treatment.
Well, what about withdrawal?
We understand that pain medication is a safety net for a lot of people. That is why we have the nurse who will work with you on your tapering plan.
Okay, I'm quite worried about my pain after the treatment. How will I manage it without medication?
Actually, what's interesting is that drugs like opioids may not be all that effective for long-term pain like back pain. Our treatment plan will help you to learn other techniques to deal with the chronic pain.
Extract 2, questions 13 to 24.
You hear a general practitioner talking to a patient called Doug Jones.
For questions 13 to 24, complete the notes with a word or short phrase. You now have 30 seconds to look at the notes.
Mr. Jones, before we proceed, I'd like to ask you some questions first. Is that all right?
Yeah, that sounds fine.
So, a bit about you. Are you currently working or are you retired?
I retired 3 years ago from an accounting firm after working there for 35 years. I was the manager of the human resources department there.
Well, I can imagine that was a very stressful job.
I guess you could say it was, but my sleep problems didn't start until after my retirement. At first, I ignored them, but I figured, what do I have to lose? I might as well see if there's anything I can do about it. So that is why I made this appointment.
So tell me a bit more about your sleep disturbance. How often are you having trouble sleeping? How is your trouble sleeping affecting your everyday life?
I think that I have trouble sleeping 2 to 3 times a week, which, like I said, is rather strange considering now I have all the time in the world to sleep and nothing to worry me. The strangest thing, though, is how often my mind just seems to go blank. I will be doing something, such as a puzzle, and then just totally lose track of where I am and what I'm doing.
Have you had any other incidents like this, where you become confused?
Yes, I had an episode the other day. I went to the hardware store to pick up a few tools for a project. Some strange man came up to me and started chit-chatting about something about my old company. I had no idea who this person was, but it was clear he knew me and had worked with me. I later worked out he had worked as an intern in my department a few years before. That was when I started to realize that I was having problems recognizing people if I met them outside of where I was accustomed to seeing them.
Have you noticed any strange changes in mood or behavior other than trouble sleeping and recognizing people?
I sometimes get quite irritated with people. It feels like my mind does not have the ability to work out what is going on in a situation before everything changes. Also, I often feel frustrated when I cannot remember the word or phrase for something simple, like chair.
I see. Let's look a bit at other aspects of your health. How much physical activity do you do, Mr. Jones?
Not all that much, unfortunately. I always envisioned my golden years walking the dog and playing with my grandchildren. But nowadays I rarely leave the house.
So there is a lack of exercise. Okay, and any health problems, such as cardiovascular disease?
Yes, I take 1 tablet a day for high blood pressure. I started taking them about 5 years ago, I think.
Mr. Jones, we will have to run some additional tests, but it appears that you may be experiencing early onset dementia. You have told me about a number of risk factors, such as cardiovascular disease, a low level of physical activity, and several years of sleep disturbance.
Is dementia serious? Or will it just make me forget things now and then? I mean, it seems as though everybody has it nowadays.
Dementia is a terminal disease in the long term. In fact, it's the second leading cause of death in Australians. Yes, you will start to be more forgetful, but it is also a brain disorder that has a negative impact on thinking, behaviour and the performance of everyday tasks. Dementia is an umbrella term for up to 200 different conditions, so we will need to do some additional work to identify your particular problems. For example, you describe difficulty recognising faces, which indicates prosopagnosia. You also mentioned sometimes feeling frustrated because you're unable to pause and reflect on what is going on around you.
Is there anything I can do to help slow the symptoms?
We need to increase your level of physical activity and get you sleeping better. This will improve your overall health as well as deal with some of these risk factors directly related to dementia.
How does sleep affect my brain?
It affects it in a number of ways. Sleep works like a sewage system for the brain. As you sleep, it clears out toxic chemicals and proteins that are involved in different types of dementia. One question, Mr. Jones. When you do fall asleep, do you wake up a lot?
Yes, I do. Also, my wife often has to jostle me to wake me up as she says I often stop breathing while I'm asleep. I used to take sleeping tablets, but I don't like the way they made me feel, so I stopped.
That is quite common in older people. You see, what happens when you stop breathing is that your brain is not getting the oxygen it needs. This is extremely detrimental for your memory. Also, when you sleep well, your brain is able to create new neurons, a process called neurogenesis. When you experience chronic sleep disruption, you impair this process and others that are important for reducing inflammation in your body. The good news is that with early intervention, it is possible to slow the disease course. As to the sleeping tablets, I would not suggest them for the long term. They are fine for a bout of poor sleep, but I don't recommend them to be used for more than 2 weeks. There are some behavioural techniques and cognitive behavioural psychological techniques for sleep disturbance. A referral to a specialist that I work with often is what I'm going to recommend now.
Part B. In this part of the test, you'll hear 6 different extracts. In each extract, you'll hear people talking in a different healthcare setting. For questions 25 to 30, choose the answer A, B, or C, which fits best according to what you hear. You'll have time to read each question before you listen. Complete your answers as you listen. Now look at question 25.
You hear a GP talking about opening and managing his own practice.
Now read the question.
Well, it was always my dream to open my own practice. I really got into medicine to develop a close relationship with my patients that will allow me to have a positive impact on their health and quality of life. Opening a private practice involves quite a number of challenges, such as hiring staff, setting up the office, and of course attracting clients. All of these challenges definitely kept me up at night. But I quickly learned that the financial running of the practice is the most challenging part. Definitely. It is always a struggle between giving each patient the time necessary to listen to their concerns, but also seeing enough patients to pay the bills. I'm currently looking at bringing on a partner to help share costs. It is important to me to
Question 26.
You hear members of a hospital committee discussing a problem in the A&E department.
Now read the question.
Attention everyone. Next on the agenda is the gap in care for patients presenting in the A&E department with acute mental health crises. Joanne, can you tell us more about this problem?
Why, yes, of course. As we have all experienced recently, we're receiving more and more patients presenting with acute mental health crises. This has brought problems for our department because we're not set up to deal with mental health issues. For example, most of the staff have not undergone specialised training in mental health, and many doctors do not feel comfortable referring to the psychiatry department. This has resulted in a gap in treatment for these patients, since once we are able to deal with the crisis, they're not directed towards longer-term treatment for their conditions. Then the cycle continues as we see the same patients come into the A&E frequently. These patients...
Question 27.
You hear a surgeon and an internist discuss a treatment plan for a patient.
Now read the question.
As you know, this patient who was involved in a car accident was just admitted with a serious fracture in his femur. He needs to be operated on as soon as possible.
Well, yes, I agree that he must be operated as soon as possible. But let's not forget he has a contusion in his stomach. An ultrasound and blood tests have been ordered and the results should be back in a few minutes. But no matter what the results are, I think we should keep the patient under observation for the next 48 hours to assess further organ damage not picked up in these initial tests. I
see your point. However, the fracture may bleed and produce an embolism. I think we should operate if the test results show that there is no internal damage. I think we should go ahead with the operation.
Question 28.
You hear an intern asking a senior colleague about a patient's treatment plan.
Now read the question.
I noticed that Mr. Harris has not gotten out of bed since surgery. I know that early ambulation is generally recommended after surgery, but...
You're quite correct. Walking improves blood flow, which in turn aids in quicker wound healing, as well as a variety of other areas. The nurses have tried to get the patient up and walking, but Mr. Harris is experiencing some problems with his balance. I've told the nurses to have Mr. Harris move his arms in circles and do some other easy exercises to improve circulation until we can get him on his feet, which should be very soon. It is important for him to start walking soon to avoid complications, such as pressure ulcers and urinary incontinence.
Oh, I see.
Question 29.
You hear a nurse talking about a new program to be introduced on her ward.
Now read the question.
Welcome all. Next on the agenda is a new program we will receive further training on next week. Sarah, would you like to tell us a bit about the program?
Yes, of course. As you all know, we often receive patients with a myriad of health problems on our ward, including endocarditis that is part of a result of chronic substance use. Starting next month, we will be integrating peer specialists into our ward to help provide support to patients with substance use disorder. The peer specialists will provide counselling to patients and will also help us to train us to support this population of patients. We all recognise that this will require patience on all sides as we learn to work alongside these new members of our team. Any concerns that you have about the programme in general or a particular peer specialist should be directed to Alicia, who works in the Community Outreach Department.
Question 30.
You hear a dermatologist talking to a patient.
Now read the question.
Hello, so what seems to be the problem?
It's so embarrassing. I have the skin of a teenager, not a 35-year-old woman. I've tried every face wash on the market, but nothing has worked.
Okay, let's see what we can do. When did this problem start?
Well, I've always had problems with my skin, but it started to get really bad about 8 months ago.
Any changes in diet or new medications?
I have started to eat less meat and more vegetables. Also, I stopped taking birth control pills about a year ago, and now I'm on injectable hormone treatments. My husband and I are trying to conceive.
Congratulations on the healthy changes in your diet. While diet can have an effect on skin, that doesn't sound like what is going on here. Depending on what injectable hormone you are taking, acne is a possible side effect. Other side effects include headaches, bloating, and weight gain. Another factor is that you stop taking the birth control pill, which is often prescribed for acne. This change, along with your fertility treatment, is the most likely explanation for the increase in your skin problems.
Part C. In this part of the test, you'll hear 2 different extracts. In each extract, you'll hear health professionals talking about aspects of their work. For questions 31 to 42, choose the answer A, B, or C, which fits best according to what you hear. Complete your answers as you listen. Now look at Extract 1. Extract 1, questions 31 to 36. You now have 90 seconds to read questions 31 to 36.
My name's Sally Grassley. I'm a thoracic surgeon at James Cook University Hospital with over 15 years of experience. Came to know my patient, John Blake, after he visited at least 10 general practitioners for his rare condition. John, I will let you tell a little bit about your medical history before talking about my proposed treatment plan.
I have always felt self-conscious about my chest wall. When other boys were running around the beach with their shirts off, I always kept my shirt on to hide my chest. You see, the breastbone sinks in quite dramatically, which, in addition to being a source of embarrassment, causes me to experience frequent breathlessness, fatigue, dizziness, and accelerated heartbeat. I can't do simple things like run up a hill or go on a hike because I can't breathe and my heart is pumping blood so fast, I feel as though I might pass out. The combination of my chest and the limitations that my condition put on my physical activity definitely shaped my adolescence and early adulthood. Over the years, I started to see GP after GP. Like Dr. Grasslake already mentioned, it was at least 10 in all. At around the 7th doctor, I finally got a name for my condition, pectus excavatum, but none of them was able to tell me if my symptoms were caused by my condition. I knew in my heart, that there was a link between the shape of my chest and my symptoms, but the doctors would not say it out loud. It also turns out that by the time I got a name for my condition, the NHS no longer offers surgery for this condition, because it says there is insufficient evidence of the benefits of surgical treatment. It is all incredibly frustrating. As I became a teenager and later young adult, my condition and its effect on my quality of life started to affect my mental health. This, combined with my negative experience with doctors, meant that I started to isolate myself and withdraw from all social interaction. I definitely did not act like your typical teen. I also started to take antidepressants. That is when I sought out a specialist.
For me, it was quite clear that John's heart was being squashed by his sternum and that this was causing his symptoms. In addition to what I could see on the scans, there was no other plausible explanation for his symptoms. I mean, in all other respects, John is a healthy young man. As I have treated other patients with John's condition, I was well aware that there is a perfectly safe and routine treatment for this condition. The standard treatment for sunken chest syndrome, or pectus excavatum, is the Nuss procedure, which is a minimally invasive procedure that has been around since the late 1980s. It involves placing one or more metal bars to correct the shape of the chest, which in turn relieves pressure on the heart. The number of bars depends on how severe the dip in the chest is. Generally, the more severe the dip in the chest, the fewer bars fit. The Nuss procedure is my recommendation for his condition. The bars typically stay in place for 2 to 3 years before needing to be removed and new bars inserted. One possible complication of the surgery is that the bars will flip, which will result in quite a lot of pain for the patient. This complication can be avoided by tackling the problem early in the patient's life, when the bone structure is still forming. In addition to there being fewer complications, recovery time for the procedure is reduced for smaller children, as their bodies more easily adapt to the bars. That is why it is particularly important for GPs and paediatricians to learn about this condition, because they are generally the first point of contact for young patients and their families. In fact, the procedure was originally developed at a children's hospital.
Unfortunately, that was not an option for me, because the GPs that I saw as a teenager did not know anything about this syndrome, and I'm still fighting for the procedure today because of the lack of public funding for the surgery. I only hope that the NHS...
Extract 2, questions 37 to 42.
You hear a presentation by radiologist Alan Jackson, who's talking about his own work with artificial intelligence.
You now have 90 seconds to read questions 37 to 42.
Hello, everyone. It's an incredible honour to be here today. I'm Alan Jackson, a radiologist and researcher with Imperial College London. I'm here to present breakthrough research on the use of artificial intelligence in reading mammogram scans. This research was conducted with a team of researchers at my institution, as well as other research institutions across the United Kingdom, in collaboration with Google, a company I'm sure everyone is very familiar with. Just to give a little background about how mammogram scans are currently read, the system that the National Health Service, better known as the NHS, uses 2 radiologists to analyse each woman's mammogram scans. Think about that for 1 second. All women in England between the ages of 47 and 73 are invited by the NHS to have a mammogram every 3 years. Getting back to my original point, occasionally a third doctor is called in to assess the images when the first 2 cannot come to an agreement. Another important fact to keep in mind about the current system of diagnosis of breast cancer is that the number of years of training that radiologists need in order to interpret mammograms is more than 10, which is quite an investment of time and resources for both the individual and the NHS. This lengthy specialised training is partially responsible for an estimated shortage of more than 1,000 radiologists across the United Kingdom. Our research study, using an AI or artificial intelligence model, shows that artificial intelligence is as good as the system currently in use at diagnosing breast cancer, and there is actually a reduction of 1.2% in false positives, as well as a reduction of 2.7% in false negatives. A false positive is when a woman is diagnosed with breast cancer, when in fact she does not have cancer, and a false negative refers to women who do have cancer, but it is not detected at the time of the scan. The improvements possible with AI mean that fewer women will be subjected to unnecessary and costly treatment, and more women who do need treatment will receive it. The way that AI works to detect breast cancer in mammogram scans is through machine learning. Machine learning involves computer algorithms that can learn and improve without being explicitly told how. This means that the algorithm will get better over time as it scans more and more images. Researchers use X-ray images of breasts of former patients from government databases. All images have been stripped of any personal information that could be used to identify the patient. Patients were initially concerned with a company like Google having access to their health records, so this was key to protecting patient privacy and making them feel at ease with this research project. Doctors and the public in general may be wondering if this means that AI will take over from human doctors. The short answer is no. We're nowhere close to letting AI loose in the laboratory. Like with any initial research project, it is still early and further research has to be done. And even then, at least one specially trained radiologist would remain in charge of diagnosis. This would mean that AI could help to do away with the need for 2 doctors to read each scan, which in turn would ease the workload and free up radiologists to do even more important things. It could also speed up diagnosis, as the computer algorithm can analyze images within seconds, and also due to the fact that computers don't need rest as they don't get tired. This will reduce wait times and worry for patients, as well as increase the likelihood of positive outcomes. This particular research project focused on women in the UK, particularly because we had ready access to millions of mammogram scans. The research team is looking to collaborate with international partners so that this research can help clinicians around the world to make more accurate diagnoses, leading to earlier detection and more successful interventions for patients as the algorithm gets better and better. I would like to thank you all for your attention, as well as my research partners and institutions here in the UK, and our colleagues at Google for all the support. I will now take questions from the audience.